आप कर रहे हैं क्या लॉगिन? पहले तो किसी एक जगह से कर लीजिए, आप होस्ट बन जाएंगे तो फिर अपने दूसरे डिवाइस को भी आपको होस्ट बना सकते हैं। रितेश दा भी बेचारे परेशान रहते हैं। रितेश दा बोल रहे हैं कि राकेश जूम लिंक भेजो। ये आपको होस्ट तो बना दिए हैं। रिकॉर्ड कर सकते हैं, अभी से ऑन है पर बहुत लंबा हो जाएगा ना, तो रिकॉर्डिंग ऑफ कर देते हैं।
हाँ, रिकॉर्डिंग ऑफ कर दूंगा।
नहीं तो आप होस्ट हैं, अभी आप रिकॉर्ड
youngers. So it gives me an immense pleasure to introduce one of my batchmates who had done really good in cardiac surgery in India, specifically the eastern part. He is an MBBS MS from Maulana Azad Medical College. Then he did his MRCS from Edinburgh. Then went to do his MCH from PGH Chandigarh. After that, he had a short stint of surgery in India, and then he went to Australia for his fellowship. He did his advanced training in adult cardiac surgery for 2 years in Austin Hospital, Melbourne. And subsequently, he did a pediatric cardiac fellowship that made him a complete surgeon from Children's Hospital at West Mid, Sydney. Ever since then, he has been attached with Narayana Health, Calcutta. He had the opportunity to see him operating at Cayman Islands also from Narayana Health, if I am not mistaken, Debasis. And he had done some terrific work, specifically in heart failure and heart transplants. So he has close to 6 cardiac transplants done by now, isn't it, Deva? And obviously, there are a lot of pediatric and adult patients who are benefiting. Few of my own relatives have been operated by him, and they are all doing well, and still keep blessing him. And we hope to hear some nice stories from Debasis today. It's an informal discussion, basically. We will touch 2-3 parts here. One part will be the cardiac surgery as a carrier. Kaushik and Debasis will have things to add, and I will just add a few words to it. Second part will be the technical parts. If somebody is interested in a consultation or any idea or what we can do to our benefit and how we can take this about. So these are the 2 parts that we will be talking about. Can I invite Debasis to start his talk?
Thanks, Krishnanu, for that introduction, and thank you all for actually sparing time and joining this. And I can see Kaushikda and Krishnanu, 2 cardiac surgeons, already in the forum, so it makes it a little easier now. What I've tried to do is just to give a broad overview of what, as Ritesh first mentioned, as about this talk, I just thought that there is nothing else that we do. You can see Krishnanu still in scrubs in a hospital on a Saturday 5 p.m. So that's our life. So it is very difficult to diverse ourselves from the core of what we are. So I thought I'll keep it close to cardiac surgery, try and make it sort of some sort of a story that we can sort of all relate to. At the same time, thank you to the EC of Praktani for making these platforms available so that we can interact with each other and obviously come to know of each other as well as meet after a long period of time. So I'll share my screen, and I've just made a small PPT, which I think would be so at any point of time, anybody can just stop. It is not meant to be a didactic lecture or anything. We're just going to talk very briefly about the evolution of heart surgery. There are some small anecdotes which I would like to share, some what is happening currently and what are the future direction. There are some patient pictures and videos. We have taken permissions for that, and there are no major disclosures for this. Before we actually go on, I just was going through some of the photographs which I had. These were actual photographs because we didn't have obviously the digital form of it. And I just collected some of our Vidyapit photographs just to share. So this was taken from my camera somewhere in 1986 or something. So this was still a dham. I believe it is no longer. When we visited, it is some sort of a museum now. So Turyanand Dham was where maximum amount of time I had spent during my time. This patch is much more greener now. This is our batch 1990, sort of after our board, sort of the candidates 1990, as we used to call it, with the group photograph that every batch has. These are so-called commanders of our batch, and I was one of them. This is Pankaj, Rajiv, and Devashish Shah and Anand Mishra. We went to Simultala, I think, for a picnic, and this is one of those pictures. 1.06, 1.07. And Kumar Rakesh, we used to do gardening in Vivekananda Dham, and this was one of those winter afternoons where we took a picture. I think this is Bama Podo Maharaj, and these were the flowers which we actually tended to. This is some holy celebration. This you can relate. This is prayer hall. Inside that is the Saraswati Puja being taken place. Some cricket match. I think it was an ex-student versus current student match where I think Anand scored some big runs. He's standing here. You can see. So these are memories which keep us connected. These are memories which keep us grounded, and obviously they are what we actually identify with. I'm just going to touch upon some interesting history of cardiac surgery, just because it is one of the relatively newer specialties, in the sense that, if you talk about general medicine, general surgery, these are hundreds of year-old specialties which have progressed through a long period of time. Ours is still a relatively new specialty, So, I mean, this was, so Theodore Billroth is one of the fathers of surgery. And at some point of time, this was before people started to think about whether there was possibility of operating on the heart. He said that any surgeon who wishes to preserve the respect of his colleagues would never actually attempt to suture the heart. So it is very difficult to perceive that just around, say, 68, 69 years ago, heart still remained an impenetrable anatomical barrier. We would not be able to access this organ. What was very unique about this organ was this was the organ which was keeping you alive by pumping blood. So it's a dynamic moving organ, probably one of the rare ones in your body. It is only one, so there are no two hearts in somebody's body. And in addition to that, it pumps blood, so you can't just access it without adequate safety measures. How it all started is also a very interesting story. So everybody knows about blue babies. So blue babies are babies which are born with some anatomical defect in their heart, in which they have their saturation. Now, thanks to COVID, everybody knows about saturation. So their saturations, oxygen saturation in the body is really low. They would be saturating somewhere in the 60s. That is why they would appear darker and blue, and they were called blue babies. And in Johns Hopkins, Baltimore, there was a very brilliant cardiologist called Helen Taussig. This lady actually suggested you can see this person there is Alfred Blaylock. And that if there was any way that we can connect a tube onto the artery to the lungs and make the saturation higher. And Vivian Thomas was a technician who helped him develop that. They did hundreds of experiments on dogs, developed some instruments. And then this is the first operation being done in Johns Hopkins, Baltimore, which was known as Blaylock-Taussig shunt. And it changed the way the outcome for these diseases were. Obviously, it was not correcting the main problem of the heart by going inside it, but it palliated them, increased their saturations, and later on they could have their surgeries done when it was possible. For those who are interested, there's a very nice Hollywood movie called Something the Lord Made, in which Alan Rickman plays the role of Alfred Blaylock. It also has the social backdrop of US at that point of time, because Vivian Thomas was a colored person, and how they overcome the entire thing of the racial discrimination part. So it's a very interesting movie on the backdrop of development of how this particular simple thing, what we think is a shunt, a tube being connected from one pipe to another pipe, changed the outlook of these babies. Then came the few steps. So as I said, what was preventing people from operating on the heart was the safety part of it. And there were no there was nothing called a division or a department of cardiac surgery ever before. In 1941 and 1951 in Minnesota, there was a visionary surgeon called Owen Wangenstein who actually first established a division. And that is where there's a surgeon called John Lewis who reduced the blood flow to the heart, and for the first time went inside the heart and closed what we know commonly as a hole in the heart. Now, from 1930 to 1940, there was another gentleman called John Gibbon. There are a lot of sentences in this slide. I haven't tinkered with it just because I wanted to read it verbatim. Then you will understand the pain of that person. So this was a young doctor who was being told by his boss to be on a night vigil because there was a patient who had a massive embolus, which means a massive clot in the artery to the lungs, and was not doing well. And he says 17 hours by the patient's size, the thought constantly recurred that the patient's hazardous condition would be improved only if we have a mechanism by which this blue blood was taken into a machine. We could oxygenate it and give it back to the patient. That would change the outlook of this patient by temporizing this problem that the patient is having. But it wasn't to happen because the technology wasn't there. And at 8 a.m., the patient finally arrested and died. And at that point, as was the norm, they immediately opened up the chest and then tried everything and found that there was a big clot in the artery to the lung, which was causing this so-called desaturation, and the patient did not survive. But that idea remained with that person, and he persisted. He persisted for the next 20 years to make what is known as the heart-lung machine. So basically, this is a machine which would take over the temporary function of your heart and your lungs, while we as surgeons can operate on that organ. And because it is outside the body, it is extracorporeal circulation. And it was in May 6, 1953. So that is what I was saying. It is a very relatively newer specialty. So May 6, 1953, when John Gibbon first time used this heart-lung machine to operate on somebody's heart. Unfortunately, his subsequent patients did not do well. So he kind of left this arena, but people persisted. And it has been a long journey. So see, at that point of time, the first heart-lung machine was a huge apparatus, which would actually sort of occupy half of an operating room. And obviously with technology, this is our operating room. You can see it occupies a small corner of the operating room. Obviously, it's got a complex set of pipes going in. So idea is very simple, that you take the blood away, the deoxygenated blood away from the heart. We sort of put it in an oxygenator to oxygenate. A roller pump gives it back to the heart. So it does the function of your heart and lungs, while we can sort of temporarily stop this and operate. There are operations which we can do without stopping the heart, but majority of the operations which are done inside the heart, you would require the heart to be stopped. So this is the journey of cardiac surgery from this particular machine to the current era. And it further sort of people, although John Gibbon did not persist, people in Mayo Clinic and other places, they kept on working on refining that machine. And finally, it was again used in 1955 by John Kirkley, another pioneer surgeon who first time used another patient who had a hole in the heart and closed it successfully. At the same time, there was another very interesting thing happening in Minnesota. This is C. Walton Lillihei, who's known as the father of congenital cardiac surgery or pediatric cardiac surgery. And we all know when a baby is inside the mother's womb, how we derive our nutrition, oxygen, everything is through a placenta. So this is basically an oxygenator that we have inside our body. And that's what connects somebody to the mother for the entire duration that the fetus is inside. Borrowing that concept, what he thought was, what if there is no machine? What if we can use another human being to temporarily serve as a pump while we operate on somebody's heart? A mind-blowing concept. So it was known as controlled clot circulation. And usually a parent was chosen with the same blood group, and they would their heart would temporarily support the other person while the surgeon would operate on this particular heart. Obviously, it is sort of, if you think now, it is sort of a pretty primitive way of doing things currently, if we think, but this was a mind-blowing concept at that point of time. And he successfully operated on a lot of babies using this concept, while there were another set of people trying to refine the machine. And soon this safer oxygenator became safer and safer. Reports were published that it was possible to operate on children with heart diseases, and successfully their defects were being tackled. At the same time, we realized that, it is not only the operation which saves the babies or any heart patient. You require a sophisticated post-operative monitoring. This was a picture which I had taken from some book which described the first cardiac ICU in Mayo Clinic. I think a lot of things have changed, but they realized that it is not only about an operation, it is also about how to take care afterwards. And obviously, this is also a journey. This is a picture from our ICU. I've taken it one of the evenings when we had a variety of cases there, and I labeled it. And that's what it looked like, So from there to there has been a journey for all of us. But it is a natural journey of progress. It is a natural journey of making things safer. It is also about making it broad-based. So as Preranjanda was saying, as to there's nothing technical about it, we all know what a heart is. We've got 4 chambers in the heart. We receive sort of deoxygenated blue blood from our veins. It goes into the right side of the heart, which pumps it to the lungs. These are oxygenators. They oxygenate the blood, put it back onto our left side, and then it goes to the rest of our body. So that is the function of this pump. And you can have defects congenitally in any portion of this heart. You can have acquired diseases where the blood supply might get affected. You can have problems in the valves and a whole lot of other diseases which can affect this very critical organ which keeps all of us alive. And there were some important milestones. So as I said, there are a lot of valves inside. So there were the first valve replacement took place in 1960 by a gentleman called Dwight Harkin. There was, again, as I said, if you go back to the slide where I showed you this pump, this was not made by John Gibbon alone, which was the company which collaborated extensively to make this was IBM. IBM at that point of time was not a computer company. And IBM collaborated with John Gibbon to actually make this. So collaboration with technology is what sort of has brought cardiac surgery to what it is today. And second thing was Albert Starr, who developed the first mechanical mitral valve, which was known as Starr-Edwards valve. Again, Edwards was Lowell Edwards, who was an engineer. And then they collaborated to actually make a prosthetic valve, a valve which would function inside somebody's body made out of metal. And this is Albert Starr with one of his first implanted patients who had that Starr-Edwards valve. At the same time, people were working in research labs. So Stanford was the place where Richard Lower and Norman Shumway were working on technique of heart transplantation. This is Norman Shumway's picture. At the same time, it was not only, it was other places in the world. In Kolkata, he reported his operations on blocked coronary arteries. This was happening in Russia. At the same time, the most dramatic sudden development which took place in 1960s were few. 1967, there was the first heart transplant done by Christian Barnard. Now, Christian Barnard trained mostly along with Norman Shumway in US, but at that point of time, the definition of brain dead and the legality of it wasn't very clear. So he was a South African who was training there, and he went to South Africa because laws were still sort of gray there, and performed what was known as the first heart transplant of the world. And the patient survived for 18 days. And this was the first time a human heart was taken off from another body and was transplanted into another individual who successfully lived for around 18 days. At the same time, there was a South American surgeon called René Favaloro who had a very dramatic and unfortunate end in the past, but he was the person who first realized that these coronary arteries, what we think the blood which goes to our main sort of muscle of the heart, if they have a blockage, can be tackled surgically by putting a bypass. So this is how the term bypass comes from. So we create an alternative channel of blood, and this came from a South American surgeon who was training in, he was still in training in US. And soon there were other techniques developed by using off-pump techniques without heart-lung machine to operate on coronary arteries. This again took place in South America. So as I said, the developments took place all around the world. And this is the Time magazine picture after Christian Barnard. He was on the cover of Time, and he himself in an interview said that on a Friday, nobody knew who Christian Barnard was. By Monday, Time magazine were asking him for a time, and he was sort of still busy getting phone calls. And soon he was on the Time magazine cover. So this was as dramatic a development like that. And these are all important milestones, because these are the giants on whose shoulders have we built upon little bit of whatever we can do today. In simultaneously, there were other legends of that time called Denton Cooley in Texas, another very big surgeon called Michael Debicki, who had sort of a lot of healthy as well as unhealthy competition between them. And these were the stalwarts of Texas who have many firsts to their credit. And you can see at that point of time, there were only very few places in the world where heart surgery was taking place. So people will visit like this in operating rooms to watch them operate. And these are pictures from operating rooms now, because it was as rare an entity like that. And this is all happening in 1950s, 60s. So that is why I was saying this is still a very, very relatively newer specialty. So as I said, it is just a prelude to what we think could be an exciting future for this particular branch. So today, when we operate, we need a sophisticated operating theater, a heart-lung machine, an ICU to take care. We need other sophisticated diagnostic gadgets like an echocardiography machine, a cath lab to diagnose, sometimes to do interventions, as well as some mechanical circulatory support devices. So it's a marriage of expertise and technology both, which is needed in our specialty. I'll just touch upon the basics of what we do as surgeons. So a common thing that we all know is bypass. What exactly is bypass? So, there are blood vessels which are like pipes supplying blood to our heart, and there is a left coronary artery and a right coronary artery. And when we have a blockage in there and the blood does not reach to where it was supposed to reach, these muscles suffer from what is known as ischemia or lack of oxygen, and we would have a heart attack. In coronary bypass, what we do is we do not tackle that particular area. We actually bypass it with grafts. So usually these days we would use arterial grafts from other areas of the body and put an alternative blood flow to that particular area. And that is why it is known as a bypass operation. So we take it from all around. So as I said, arterial grafts have shown to be slightly longer lasting. So we take it from your chest wall, which is known as internal mammary artery. Sometimes we take it from the forearm, like the radial artery, or the good old veins from the leg. And that is what is known as coronary bypass. Now, this also, again, is a blend of technology and expertise, because as time has progressed, it has moved from a proper sort of a heart-lung machine done operation to an off-pump operation, which is known as OPCAB, to minimally invasive surgeries where we do not open the full chest, to even doing it robotically. And this has been sufficiently abled by things like stabilizers, positioning devices, and ultimately robots. So as I said, technology has been an integral part of this. And when we say off-pump surgery, what we do is we don't stop the heart. We have these specialized retractors, which are called octopus and starfish, and they stabilize the heart temporarily in that particular area where we want to operate. We would harvest another artery from another area of the body, stabilize that particular area of the heart while keeping the patient's blood pressure and other parameters okay, and put a bypass graft, what is known as off-pump coronary surgery. And in India, I think we do one of the largest number of off-pump coronary surgeries for a variety of reasons, but the experience is definitely the largest in this part of the world. In addition to that, obviously, every specialty has undergone a thing where we would want to do it without making big incisions and access. And so some of these operations are possible by minimal access, where you put a port access, and you even have sort of a robotic system where the surgeon is actually sitting in a console away from the thing, and robotic arms are introduced inside the patient's body, and you can actually do the operation sitting outside, in a console. As I said, technology again plays I'm sure there are people from various backgrounds here, so technical part of it will be, so these are engineers who played a significant role in designing these. So there are metallic valves, there are valves derived from animals, and basically we have to provide some form of a valve inside a pipe which would allow a unidirectional flow of blood. That is the main idea. And it again comes from, these have all gone design refinements over a period of time, and current valves are obviously far more safer than what they used to be many years ago. And again, we have realized that putting an artificial valve is probably not the best of the solutions. So we have all sort of trained and undergone a journey where we can repair most of these valves, realizing that patients' own valves are probably the best. Although it comes at a price of a reoperation later sometimes, but we would prefer to repair a valve rather than replacing it. In addition to that, as I said, heart failure. What exactly is heart failure? When there is a pump which is supposed to pump a certain amount of blood and it's not able to. So that is when we say the heart is failing. So it leads to fluids being accumulated in various parts of the body, and you would want it to be replaced by another heart. There is very basic research done in some stem cell transplant of questionable nature. However, devices are a solution. So you have these devices which are known as ventricular assist devices. So these are artificial pumps which can be put on the patient's body to either temporarily and in some day to actually sort of support them permanently with that device rather than going for transplant, going to what is known as total artificial heart. I'm sure Kaushikda is more exposed to these devices because of access and his expertise, and he would be able to tell you far more about that than me. But this is a reality which is happening. And in addition to that, obviously, heart transplant has undergone also a lot of progress. And these days, it is far more safer because of the way we manage our immunosuppression, the way we manage our drugs, and the post-operative scenario. This is just to give an idea. So this was one of the recent heart transplants. So this heart is beating in somebody else's body. This heart is beating in somebody else's body in a different hospital. 4 hours later, this has been transplanted into some other person whose own heart wasn't functioning, and this person unfortunately was brain dead. So this has been taken off from here and has been transplanted here, and is doing just fine. So that is the power of these surgeries. That is the power of blending technology with surgical expertise, that you can actually offer these solutions to patients who have no other option than getting a new organ. These are few of, during the COVID times, everything was a news item. So as you know, everything goes on to lay press in India. And these are few of our heart transplants which were covered in lay press recently in the last year, especially in the COVID times. In addition to that, so we have touched upon what is coronary artery disease, which is blockage of the heart vessels, the valvular heart disease, the heart failure part. And a very close to heart thing is congenital heart surgery, which is done in children who are born with defects. So they are commonly known as hole in the heart, which is ASD. These are various chambers of the heart where you could have a hole. I talked about blue babies and the story of BT shunt, which is done for patients who have deoxygenated blood. So they are cyanotic heart diseases. And you might think as to these children undergo sometimes multiple surgeries. Sometimes they undergo a very long hospitalization. Is it worth it? So a normal person, sometimes parents come to us with this question, because in India, sometimes they would come from various strata of society, and it's probably far more easier for them to make another baby. So they would ask this question as to, should I sort of take my child in this journey or not? And I put this slide just to give an idea that why to take that kid along that journey. So this is Buchanan, who was born in 1982, is part of the Australian test team. And this fellow has undergone 3 surgeries for a blue baby syndrome known as tetralogy of Fallot. So he had a BT shunt, and then he had a full repair, and later on he underwent a pulmonary valve replacement. So, and he could play competitive sport. Not all children would be able to play competitive sports, but they would be able to lead a pretty normal life if they have been treated appropriately at time. On your other side is a gentleman called Sean White, who was again an American professional snowboarder. He had endured 2 heart surgeries before the age of 1 year. So there is a meaningful existence in spite of having been born with a disadvantage of a malformed heart. If treated at time, they can do just as well as you, me, or anybody else. Yeah. And in future, I think there are already sort of procedures being done when the fetus is inside the mother. So it is possible. You have seen in COVID era how many lives have been saved with ECMO. An ECMO is nothing but a sophisticated heart-lung machine in miniature, which is far more safer. The pump is of a different nature. I've talked about some robotic advancement. I've talked about how valves are important in the heart, and now there is a technology to put these valves inside your heart without actually operating by transcatheter technology. There's a lot of work being done in total artificial heart, and there is also a lot of work being done by allied professionals in IT and other industries who are integrating various prediction indices of adverse event by using artificial intelligence. So this is another big exciting area for healthcare. In cardiac surgery, what it means is obviously a patient is usually very sick after an operation, if at all, would require a lot of attention. And we monitor various parameters. And AI is currently being used to integrate all these data that we collect from various patients to whether have a composite index. So no longer monitor the heart rate, the blood pressure, and other things that we usually do, but to have an integrated index based on hardcore data, which number will predict that, well, this is the time to intervene. This patient is probably going to not do well. So again, this is probably the future where there are a lot of work already being done, and I'm sure it will someday become a reality where such an index will make this particular thing much more safer. And in India, because of our population, although we started very late in heart surgery, we still do a fair amount of numbers. So approximately 150,000 individuals undergo adult cardiac surgery in India. Approximately 35 to 40,000 congenital procedures takes place. And approximately around 200 heart transplants take place in India these days. So, and they are distributed all across the country. There are still areas which are underserved. But again, it has made a huge journey in terms of making it broad-based in India. So it is no longer limited to bigger cities. These days, there are a lot of centers in smaller places, tier 2 cities, which do exemplary work. These are, and again, sort of in our part of the world, patient comes from all over. So it is our neighboring countries from which we get, these are some of the patients from Africa who had come to our unit to get operated, children with congenital heart disease. These are patients from Afghanistan. I'm not sure what will happen in future as to whether they have access. This is again a child from Burma, Myanmar, who came to our unit for operation. So it is literally United Nations of the world kind of existence at some point of time. And they all get, because it happened, it is a good positive news. We don't mind it getting published in lay press just to spread the awareness. And these are all some of the news items published in 2000. Again, as I was saying, that this is one particular child from Burma who underwent a very complicated operation of an arch repair, an arterial switch, a VSD closure, and went home. And 6 months later, no, this is probably a year later, on WhatsApp, the parents send us this video. This kid is now sort of walking, playing, becoming naughty, as good as any normal child. And this is what keeps us going, you know. So this was almost like a 6-7 hour operation. The chest was kept open for 2 days, and then we closed in ICU. The patient stayed in ICU for almost 7 days, went home on 14th day, and then is doing this. And so this is what makes it worth. So as I was saying, we would just touch upon as to what it means to do this specialty. So first, cardiologists and cardiac surgeons are two different specialties. Cardiologists are our physician counterparts who also do a lot of interventions. What we do is operating on the heart. So most of our patients would come from cardiology, and we had this specialty, because of the complexity, has its own challenges. So we undergo a long training period, and there is some sort of a steep learning curve compared to some of the specialties, although completely surmountable. We have extremely long hours because of the nature of work that we do. It always needs a big institutional setup, so it cannot be done at very small places. And it is a capital intensive exercise for the hospital. So people who invest money in healthcare, this would be an expensive investment, because we need a lot of technology and equipment, as you just saw. And it also requires a large, well-organized team to deliver results. So it is not a one person's job here at all. It requires a big team. So what we have all realized as cardiac surgeons that, although it's very interesting, it's very challenging, somebody who has already become a physician and wants to take up a specialty like this just has to know that he really wants to do it. If you like doing it, you will persist. If you're just doing it for just another job, you will probably get sort of worn out very soon. So if this is the only thing which can make you happy in terms of your professional satisfaction, you are ready for undergoing these long hours of training as well as enduring this later on when you're practicing, there is a point of taking this up because of those satisfactions which cannot be measured in sort of objective terms of material wealth. So I'll just leave you with a quote of Marcel Proust saying that the real voyage of discovery consists not in seeking new landscapes, but in having new eyes. This is a established specialty now. We just have to see that this is the one which will work for me if somebody wants to take it up and then undergo the journey. As I said, it requires a well-organized team. These are pictures from our operating theater. They are pictures from our core team of anesthesia, intensive care, and surgeons. These are our rest of our staff. And this is a picture taken by one of my colleagues from a plane from Kolkata. And our hospital is somewhere here on the other side of the second Hooghly Bridge. And you can see the grounds of Eden Garden, and a small sort of that white thing is actually the Victoria Memorial. So I've been living in Kolkata since 2009, although I was never grew up in the city. But these years after 2009 have been extremely gratifying. And thank you again for the attention. Thank you again for listening to this. And I hope it made some sense as to what I was trying to say about the specialty. And I gave you some sort of an overview of what cardiac surgery is about, how it all started, and where we think it can be headed to. Thank you again.
Thank you, Debasis. Extensive, very nice presentation.
There was this question, when do we use a pacemaker? Because that's the first thing that I knew and probably know until now. Pacemaker ache. So when do you use a pacemaker?
So a pacemaker, so as I said, there is an electrical part to the heart and there is a blood supply part to the heart. So our heart has an electrical supply which makes it beat in rhythm. When it gets affected, that is when you need a pacemaker. So these are electrical disturbances of the heart. Pacemakers would generally be placed by cardiologists without an operation, although initially they were placed by putting a patient under the knife. And pacemakers basically sort out your rhythm issues. So when your heart is beating slower than expected, when it is throwing up sort of abnormal rhythms, then is when a person would require a pacemaker.
Debasis, thank you for this great presentation.
Hi, Rajesh.
Hi. I have a very simple question, which I think many of us would be, putting it across to you. We are now on the other side of 40s.
Sure.
What are the few things? Of course, we hear that Indians are prone because of their genetic or veins or body structure, sedentary lifestyle, eating habit, whatever. So what are 5 takeaways, as in, what are the things that we can do to ensure that we don't have to come to you? We will have to come to you.
Of course, of course, it's a very legitimate question, and you can see these young patients getting affected by all sort of things in the recent sort of past. What it is basically to prevent, what we need is just very basics. So first thing is watching what we eat. Obviously keeping a tab on your calories, your distribution of carbohydrate, proteins, and other fatty elements, eating healthy, exercising daily. Exercising does not mean sort of going to the gym and pumping up iron every day. Even if you walk sort of 5 days a week to 30 to 45 minutes, that is something which would take you a long way. So eating healthy, exercising regularly, avoiding smoking if it is possible. And fourth thing would be to undergo regular all of you are very aware. So you would be undergoing sort of routine tests like getting your bloods checked for cholesterol, any other things annually, or even sort of after 2 years after you're 40, just to sort of know that anything is going wrong in spite of your being symptomatically normal. So these are a few things which you should do to prevent: eating healthy, exercising regularly, keeping your stress levels, because that's again a
How
precipitant.
do you control stress?
So that is probably
someone
not
like me has no
answer.
stress. I'm talking about others. I have no stress. I mean,
so that's again,
but,
this is probably best answered by other people, but that stress definitely leads to these problems. So if you can keep that in control as well, again, I think stress management again comes if you eat healthy, if you exercise regularly, automatically you're on the right path. So these are the main things: getting checkups regularly, as well as avoidance of smoking.
I
Because
think we hardly get our checkups. I think that is one.
Some of the organizations actually have made it mandatory for all employees to undergo an annual health checkup. I think that is.
So Rajesh, if you noticed, he said avoid smoking. He didn't say avoid drinking. So maybe you can take a segue on how to manage stress.
Rahul Shubham from 2004 batch has a question. Can you please, Rahul?
Yes. Hi, Dada. Debasis, first of all, a great session. I mean, a very nice presentation, exactly, with all those videos and visuals. But I have a very normal question that I have been hearing since my childhood. I mean, whenever we sit down, we have a tendency to shake our legs, right? We shake our legs. So in early childhood, mom, dad, or some elders or parents used to like say different things, like don't shake your legs and all. Later, somehow through outer knowledge and all, we came to know like shaking legs is a kind of something related to heart disease or something. You are either in anxiety, or it is said like if you are shaking your leg, it's a kind of mild symptoms of something related to heart. So if we consciously stop shaking leg, so does it solve it? Or if I observe myself shaking leg, like right now I was watching your session, as very involuntarily I started shaking, and suddenly I noticed I'm shaking my leg. So I mean, anything on that? I mean, if I consciously stop it, so does that solve if there is any problem related to heart or something, does it solve it, or is it a like very early indication of some kind of things related to heart?
Right. I think I'll take Kaushik Das and Krishnanu's help. I don't think heart disease has got anything to do with this at all. I think this is again one of those myths which is probably not really correct, that shaking your legs is a symptom of heart disease, or sort of stopping to shake your legs will make it any better. So I think it is again one of those things which have been sort of going on from generation to generation. And I don't think there is any scientific evidence to this, so that's what I don't think you should worry about it.
Okay. Great.
Debasis, there's a question from Mithilesh now. Kaushik Da, we will hear from you as well on this topic again.
Sure.
So one of the things that you said, going forward, is AI and its use in actually managing and handling patients. How far, I guess, the other sort of developing area.
What they're doing is like let's say I have 10 patients in my ICU, there are 10 monitors which are giving real-time data of blood pressure, his central venous pressures, his other parameters like ECG, and they're all sort of coming individually for one particular patient, and then we are trying to predict any event for him or watch him very closely. What they're trying to do is all these data from, let's say, so this study was being done in Toronto, and where they were trying to integrate these data from all the devices in the hospital, and then trying to correlate it with adverse events which are happening to the patients. Whether an isolated blood pressure, whether we can develop an index by which there is a figure which tells us that the adversity score is now 5, this patient might crash in another 10 minutes, based on conglomerate of all this data. That is where they're integrating this.
My question is slightly different. I thought the other sort of, though very nascent right now, potential future development could be sort of printing, your stem cell derived things. I know of at least some labs which are very actively working on it. We even have a prototypic heart. But in real life, how long do you think that has to go before it will become a reality? Is it a decade from now?
So two things. I think stem cells have been used for using sort of in areas of heart which are no longer functional. there has been some research where there are sort of non-functional dead areas of heart where if you can inject stem cells and make them work, this has still not worked so far dramatically. Yes, they have been able to sort of grow some sort of a lab-based tissue engineered heart, which can pump, but whether it can actually support a human body completely, there's still sort of some journey away from it. Although I'd be happy to know it from Kaushikda or Krishnanu if I'm saying correct or wrong, but so.
Debasis, your talk has been very extensive, and I'll just invite Kaushikda to have a few words on the topic.
No, Debasis, that was excellent and a very succinct summary of the journey that we have made as a specialty. And both you and Krishnanu, encourage me that there are still young people who take on the challenges, because the excitement and the Times magazine coverage has certainly disappeared from our life. The stress and the hard work still very much remains, and yet we are here persevering and helping. To look at Krishnanu still in his scrubs at 5 p.m. So the future is secure for our patients, for our country worldwide. So that's very, very good. So just anecdotally, I mean, I'll share that I had the good fortune to operate in the same hospital and operating room where the first blue baby operation was done when I was doing my training at Hopkins. And an interesting anecdote was, if you remember, Dr. Vincent Gott from the Gott Shunt reputation. Yep. Yes. So he had interviewed me for my fellowship selection, and he would narrate an anecdote that in those days, in the early days of congenital surgery, when a baby was being transferred from the operating room to the ICU, the intern's job was to go and scout and clear all the electrical outlets from the OR to the ICU, because there was no battery technology yet to support the pacemakers that these babies were coming out of after their surgery. And the intern would hold the plug, he will plug it in, it'll be on the leash of a long wire, and then as soon as they're almost at the end of it, he'll quickly go and plug it in the next outlet, and that's how the baby would make a safe journey from the OR to the ICU. Fast forward that 20-30 years, marriage of technology, science, engineering to medical requirements. Now it's all implantable, battery-powered pacemakers and devices. Yep. And we recently, coming to this bioengineered heart and mechanical circulatory support, we recently went through venture capital funding onwards to phase 1 trials for our device called Charisma, which is now a fully percutaneously implantable, non-wired. So there are no external drive lines to power the device, which is getting remotely powered. And the reason we chose the engineering solution rather than a biological solution was there are so many variables in the biological solution that we can't control. Engineering solutions are much more easier to understand and comprehend.
And you can take it off the shelf, you're not relying on.
Exactly. And like, we are at this point very good at understanding 1 + 1 becomes 2. So linear thinking we are great at. We are just about trying to understand the multidimensional thinking. For example, a cell not only needs the right genes, but it also needs the right environment. The extracellular matrix and stuff like that. So we probably still are a good few decades away from being able to develop a full biological heart, but very interesting. And again, congratulations on you and Krishnanu for the great work that you're doing in what I would still call a resource wrapped in one. Fantastic. Congratulations.
Raga, can you go on mute? Raga, mute.
I have one question for you, Debasis.
Yes.
Please
Karthik.
And first of all, congratulations for the wonderful presentation. I think it was, and I wish my son was awake because he keeps asking me questions about heart and how it works and what all that, because he's somehow very curious about it, and one day I will send him to you to answer all these questions.
Last when I met him, he was interested in black cars.
Yeah, and that is going to remain on his life.
Somebody is on unmute. I think it's disturbing the session.
Yeah, everybody else requests you to go
can
on mute.
use the host can mute the participants who are like.
So I have a question which is, and you would know where I'm coming from. In your surgeries, where you perform your surgeries and your ICUs and the hospitals, in today's date, the way the hospitals are designed and the way the surgeries are designed, your circulation, the way you have to move, your scrub areas and all, do you feel any shortcomings in today that you would
absolutely
think should be improved?
No, yeah, absolutely, because we have seen sort of array of sort of very basic mistakes being made in various hospitals that we have worked across in our career, and you would suddenly find that it would make sense to have your cath lab and your operating room in the same floor as well as in the ICU. But there are umpteen number of hospitals where a patient after an operation has to undergo a long journey through a lift to a different floor. So this is as basic as that. There are hospitals which are better designed now, where they are sort of more or less more ergonomically organized. But still, you will find that there's a beautiful hospital, without naming it, which made a very sort of well-organized thing. And just the entrance to the OR also had a side entrance for the sluice room where all the dirty linen would go away from. And that just sort of makes it completely counterintuitive. So it does happen because I think, again, if there is somebody from an architecture designing background who sits with the hospital management plus a clinical person, an actual person who would understand this as to how to design it better, then only we can overcome this. But these mistakes are very commonly seen especially in our part of the world, where sometimes the building might be a half-built mall which has been converted into a hospital. So we do see these glaring mistakes being in our.
So I think that is something. That's something we as architects also always try and tell this management guys from the hospitals that you should get us into the same room with some surgeons and doctors so that we understand what they need instead of you telling us what you need.
Yes.
But maybe that is the way forward.
Actually, in fact, our group is trying to convert one hospital to one hotel to a hospital. So I hope they do the justice to it. But
and that is exactly why healthcare architecture is a specialized field today.
Absolutely, I can imagine it should be.
Yeah.
So Dada, you all would be happy to know. I think there are 3 architects that I personally know who are on this Adda right now, listening to it. So yes, definitely some help, some hearing could be beneficial to all of us.
Healthcare architecture is quite a specialized field these days, and thankfully people have started recognizing that. Thank you.
So I guess we are at the end of the session today.
Dada, we have one more question from Rahul.
Okay.
Rahul asked us how much blockage is considered special. Yeah, so how do we actually calculate that is based on an angiogram. Anything more than so, it is not very important to actually understand the percentage of it. Your cardiologist or surgeon will tell you that it is a significant block or not. But mostly we used to consider that more than 70% of any sort of diameter reduction is a significant block, but that has undergone a change. These days we have specialized things like FFR and other things to measure it. So even sometimes a 50% lesion is significant, and more. So it is also based on functionality of that lesion. So your cardiologist or surgeon would be the best judge to tell you whether it is significant or not. So attaching a numerical value of a percentage for a patient or their relatives is probably not the way to go. If you're trusting a cardiologist or a surgeon with your heart, I think if he says that the lesion is significant, most likely it is above 50% blockage, close to 70 and above.
Also the location of the blockage. If it is a left main 30% also, it can be significant for a person who's having a problem.
I have a lighter question also. So what was so special about 90 batch? लालदा ने क्या ऐसा पढ़ाया कि इतने world class doctor है उस batch में? So you look across India, world, everywhere it is world class doctor. All are from 90 batch. कुछ तो special पढ़ाया होगा लालदा ने.
Lalda was funny.
ऐसा कुछ नहीं है. When you saw Debashish's first slide, I think he said that somebody was by the patient side for 17 hours. We have to sometimes do it for 24 hours. So it is just the perseverance, I think.
Devashish,
it was a great session, Devashish.
Hey, Bala.
अरे यार ड्राइव कर रहा हूँ इसलिए I could not talk, but a short video just to say thank you. Devashish, so great to listen to you. बहुत बढ़िया.
Thank you.
इनफॉर्मल अपना व्हाट्सएप ग्रुप में तो बहुत इधर उधर का बात होता है. प्रोफेशनल के तौर पे देखना नहीं हो पाता है. So it's great listening to you.
Thank you. Thank you. We in 1990 batch for others, what we have is a WhatsApp group where we still ring the rising bell at 5 a.m. So we have a bell icon which goes 3 times, which either is me, Bala, or somebody, mostly me. So at 5 o'clock,
with a cup of tea and biscuits there.
So there was one question: what kind of food would help heart? Cashew would help.
No.
Fried cashew.
For 1990 people, this is a loaded question, but I'll try and make it broad-based by saying that, well, dry fruits are healthy, but not probably cashew, you know. An almond would be a better choice if you munch on this thing, or even walnut for that matter. Cashew is for other things.
Actually, he was asking what's the combination with a single malt or something like that.
As long as we do it occasionally and in moderation, cashew and single malt is
always welcome.
Or Kaju Feni.
Wonderful. Great job, Debashish.
Wonderful session and great to see so many people from 1988 batch. Priyaranjan Jha, first time I heard Kausik Mandal, then Debjit Ghosh, and then Indranil Majumdar. So many people from 88 batch. Actually, I am from 87 batch. So 87, 88, 89, 90, most of them I remember. Kistano's name is just coming in my mind. But Debasis Das also. And some of the, yes, is a long years. So many people I might not be remembering. But yes, Joyjit Ghosh is there again. Then Balaji is there. So many people. It's a good one. A nice presentation.
One thing I
also
Kaushik
Da, I just wanted to say hello to Kaushik Da because I think me and Kaushik Da were part of the Delhi batch.
Delhi batch.
It was great to see you after so long, Kaushik Da.
The batch used to consist of only 2 persons.
Correct.
And it was still very exotic, you know, Delhi batch. You know, people coming to from Delhi, you know, it was a big thing, you know.
So Rahul had a question.
And the good old train that time was Tufan Mail. I've never taken it ever after that time.
I think there was another person called Shayanton or somebody who was there.
Shayanton there, right. That's correct.
And once his father was supposed to be the guardian in the train and they missed the train. And I think your dad or my dad hopped into the train to take us back.
Priyaranjanda had some question, I think. Priyaranjanda, you were saying.
Just to Rahul's question, if you remember, there always used to be a conflict with the next batch, right? And an affection with the alternate batch. I think 90 batch got our attention and affection. That's why they became such good doctors.
Amazing, Priyaranjanda. ये तो बात सच है.
Wonderful say.
बहुत प्यार मिलता था आप लोगों से.
We remember Priyaranjanda umpiring and favoring us.
Always.
Good.
Priyaranjanda, आपका नंबर चाहिए.
क्या नंबर? ले लो यार. I just type in chat.
ठीक है.
Great. Thank you.
Excellent.
Thank you, everybody. Yeah, it has been a
very well done.
Great evening. Yeah, it was good to see so many seniors, colleagues, juniors, everybody together. I had been sort of attending one of two of these Adda sessions, but this is a great initiative by our Praktani EC and everybody.
Yes.
Continue doing this.
And 3 cheers for EC and Praktani.
precious.
Very true. So some people
Thank
are
you.
working selflessly. Really, I am very happy to see that, because see, this is one effort wherein today at least I could see Kaushik Mandal after so long years. And 88 he passed out. So I think from 88 till now, first time I am seeing him. So it's a really wonderful effort to make everyone in one place. I think there are some Rahul, then Ritesh and Balaji is also there working on it. So everyone is good. Wonderful. Priyaranjan?
Yes.
Priyaranjan? ये थोड़ा वेट कम हुआ लग रहा है तुम्हारा.
स्ट्रेस कम कर रहा हूँ. कॉल करता हूँ नंदिता. Thanks guys, very well done.
Thank you everybody.
With due permission of the senior.
নমস্কার. Really, Kaushik, তোর সাথে কথা বলে দারুণ লাগলো, মানে তোর কথাগুলো শুনেও দারুণ লাগলো. Wonderful.
তোমার আর যাই হোক, তোমাদের বাড়িতে I think আমরা রিউনিয়নের